Did my article on the initiation of long-acting insulin as a component of initial management of DKA. So a little bit of background. What's DKA? It's one of the two extremes in the spectrum of hyperglycemic crisis, the other one being HHS. We've got insulin deficiency and resistance, increased catecholamines, cortisol, and growth hormone, oppose the action of insulin, and ketone body formation. And if y'all want more information about that, I got a long paragraph on this piece of paper up here I can read to you. But I'm going to move on. What defines DKA? According to our friend Marino, you have a blood glucose greater than 250, plasma bicarb less than 18, plasma pH less than 7.3, got an elevated anion gap, and for this study it was less than, that should be greater than 16, sorry. And ketones in the blood or urine. Usually you see DKA with type 1, but some people with type 2 can also have DKA. Usually if they're sick or there's a condition or a particular manifestation of type 2 diabetes called ketosis prone diabetes. So you have that. And it's often seen in those less than age 65. According to the CDC, hospital discharges are increasing for DKA, so more people are coming in with it as the primary diagnosis based on that. However, the length of stay is decreasing, so I guess that's good. As far as the management goes, it's pretty protocolized, similar everywhere. You want to correct the dehydration, correct the electrolyte imbalances, correct the acidosis, and figure out what's causing it and fix it so it goes away. And we have our own little protocol for managing DKA, so if anyone's forgotten, it's large volume resuscitation with isotonic fluids. They get an insulin drip and a bolus. If you're here in Atlanta, they get it with the glucomander. If you're not, the nurses calculate it with magic. You trend and correct the electrolytes, identify and manage the underlying cause, and eventually, once they're off the drip, you're going to put them on some sub-Q long-acting insulin or restart their home dose or start them on new if they aren't on it already. So why would you want to consider changing the management of DKA if you already have a system that works? It's a good question. So you could ease the transition to sub-Q insulin, so you wouldn't have the dreaded reopening of the anion gap and the return to the ICU. You could decrease possibly the length of stay in your ICU, which that's a pretty big deal if you've only got 20-something beds and 5 holds in the ER. You could decrease costs of hospital stay and decrease the length of stay of the patients. So, this is my study. Prospective randomized trial of insulin glargine in acute management of DKA in the emergency room. So this is a pilot study, it's pretty small. Some benefits of glargine that they wanted to investigate. It's got a stable plasma level. It could decrease the time to getting off of the drip. And then it's long acting. So it could expedite the dispo of the patient and get them out quicker. And the objectives of my trial, so they wanted to see if it decreases time to the closure of the anion gap. Does it really decrease length of stay or ICU admissions, which they did it in the ER, so I guess that was pretty pertinent for them. And can you do this safely? Being in a pilot study, it was pretty small, 40 participants. So I think that's one of the primary things is you want to use a small sample so you make sure you don't kill a bunch of people when you first start it. So like I was saying, it's a pretty small study. It's a prospective randomized single-blind trial. 40 participants, 20 per arm of the study. They did it in 2 hospitals in Houston. One was a county ER, the level 3 trauma center that had approximately 70,000 admissions a year, and then a large tertiary care ER in a level 1 trauma center. And the sample was a convenience sample, so essentially if you came in, they diagnosed you with DKA, and consented you and put you in the study. So inclusion criteria: blood glucose greater than 200, pH less than 7.3, bicarb less than 18, and ketonemia and ketonuria, and eye gap greater than 16. So you qualify. Exclusion: if you were on vasopressors, if you're pregnant, if you're end-stage renal, if you're a prisoner, if you said no, if you had to go emergently to surgery, or if they had to transfer you out somewhere else. And he obviously is in DKA because he's intoxicated, and he's real sad because he can't be in the study because he's a prisoner. So the protocol for the study: they got these patients, they figured out they're hyperglycemic, so they completed their initial labs and said, oh man, they're in DKA. So then they randomized and consented them. Everyone was initially treated with a 2-liter bolus, which is kind of interesting. I thought it was pretty small, considering we give like 6 or 7 liters sometimes. And then they were all started on the insulin drip at 0.1 units per kilogram per hour. And then this is where you run into the difference. In the experimental group, the patients were started on long-acting within 2 hours of diagnosis. They got 0.3 units per kilogram of glargine within 2 hours. And then you kind of monitor the lab data, titrate the insulin drip as you normally would, and then you run into another difference. On closure of the NI gap, the control people got the glargine, and then the insulin drip was continued for 2 hours and then turned off. And the experimental people, they just turned the insulin drip off. They didn't get another dose of glargine until 24 hours after their first dose. And this is just a picture of it for people who like that. As far as findings, the primary objective was time to closure of the anion gap, and that was decreased from 10.2 in experimental and 11.6 in control hours. And then secondary of those objectives, the length of stay was decreased as well from 4.6 to 3.9 in the experimental group. So that's good. However, other secondary objectives that they were investigating, which would be rate of ICU admission, hypoglycemia, and ICU length of stay, were pretty similar between the two arms of the study. So, in conclusion, if you start the insulin glargine at the diagnosis of DKA, per this little bitty study, pilot study, you had an overall decreased length of stay and decreased time to closure of the anion gap. That's wonderful, yay. But there are some limitations to the study. Obviously, it's a very small study. It's 40 participants. It's a pilot study. So those were some pretty main ones that I thought about. So you may wonder, well, why did you waste your time doing this project on a pilot study that's only got 40 participants? Well, there's other people doing this out there. Oops. According to the Joint British Diabetes Society Management of DKA guidelines, they're saying that the continuation of basal long-acting insulin is pretty widespread over there. And they say that while it's not necessarily recommended, that it's a common practice and it's thought to be safe. And then also, when I went to the CHEST conference, they're apparently doing this over at Vanderbilt as well. So they did an article about it, and they say it works pretty good for them. So some things to ponder. What would it take for us to be able to start using this practice, start doing the long-acting insulin in the early management of DKA? Because we're pretty set on this insulin drip theory, and so we obviously need more studies out there. And do we think this could really reduce the amount of ICU admissions, considering especially we wouldn't have control over that because we get them after they come to the ICU? It'd be up to the ERs to dose this long-acting insulin and really initiate. And then, how could we at Georgia Lung be on the cutting edge of ICU use of long-acting insulin in the ICU and diabetes management? No, he doesn't know what to say. So, what kind of questions do y'all have?
Why were prisoners excluded? Does that have to do with
I think it's like a legal thing.
It's a law.
Yeah.
No, I thought maybe it was like the prison system was like refusing to pay for
I think it's has to do with like the IRB board, huh? Like they technically can't consent themselves because they're forced.
As members of the IRB.
Yeah.
Like it depends if they're already in the study, then there can be some provisions, but a lot of times they get kicked out when they become imprisoned. Because technically you can sometimes say that it violates their civil rights and say that you coerce them because they're incarcerated to be a part of the study.
Any more questions? Do y'all think that this would work? Does anybody think it's legit?
I think logistically it depends on how your ER and admission, I guess is set up. With length of stay being a metric, the ER measures so closely, they're trying to get you out. I don't think in our system that we may see enough correction of their gap and acidosis for us to really decelerate them from an ICU admission.
That's what I thought too.
At another facility where they hold them down in the ER maybe longer, or they have more room, or it's busy, then I think it could potentially cause people to not be in ICU. But I don't think for our system, I don't think it would work.
Well, plus, I think if you're reaching an ICU length of stay of like 10 hour, or gap closure of 10 hours versus 11 hours, that buys you 24 hours in the ICU anyway, whether you're hitting either of those metrics. I don't know if it makes a difference on ICU length of stay, in our system at least.
And I've found that people get clogged up in the ICU not because they're, not off the drip or because their gap's not closed, just basic mobility of patients out of the hospital.
I think from a financial perspective, the length of hospital stay, it's like point something a day difference, but over the long term and on a whole scale, like a large scale, that could be really significant cost savings.
Case, what's your quote on that the other day? On the length of stay reduction?
Oh, here for a half-day reduction in the patient population usually translates to 4 bed days. And so if you shave a little bit off the population of patients, it can have a pretty significant. I guess though, there's no statistically significant difference in these outcomes, right? So that should mean that this didn't change it. And while the authors are arguing that it can be studied more robustly, until that time, the question would be, would we not just be adding something that's adding more complexity to the management algorithms, not necessarily altering it. So if you believe that it should alter the outcomes, then why did it not? Were they not aggressive enough with the long-acting insulin?
They didn't use much.
The hypoglycemia rates are similar. I wonder if they had a larger trial and they had some different arms, and one of them they saw an increased hypoglycemia rate in that treatment arm. Would that show a better outcome? Now, I guess the other piece is how good can you get it? Like if you're dealing with something that has a big impact and can really swing the length of stay down faster. If you're going from 10 to 6, that's one thing. If you're going from 6 to 5, 4, like how fast can you close that down? And then I wonder about how I couldn't see clearly their inclusion exclusion criteria when I was trying to find some of that in terms of are they putting so we've all seen the brittle diabetics that are on a lot of insulin as outpatient that they can load back up. Maybe that cohort of patients that are requiring a lot different insulin support get that on board faster. And the other thing I just was thinking about is here we use endocrine a lot.
Yeah.
I think they do a really good job of estimating when to add back those long actives. It seems like I don't see a lot of length of stay prolongation of the reinstitution of their long active regimens. So I wonder what their management structure is when they were adding those back and then control early on to confound. So, I wonder if you look at new newly diagnosed diabetics and put the long-acting instead. When we're managing DKA at Henry, Fayette, Newman, and Atlanta, do y'all think there's significant variability in how we are managing DKA in those environments?
I don't think us as the group, really. I mean, I use the same protocol y'all taught me up here, but I mean, we don't have endocrine down there, so I think there is a big difference when it comes to restarting the long-acting insulin. I've actually asked a bunch of people about this who work down there, and everybody seems to have a different method of doing it. Some people use the chart, like there's a little chart you can click on and it'll tell you what to give them. Some people use the 0.5 to 0.8.
When you say some people, you're referring to those in this room? Is that our people?
Yes,
Yeah.
our
There's a
people.
shame. That's a hole in our training program. After we started putting them down there, I didn't even think about it. We use all glucomander and have heavy endo involvement, and they don't have either of those things. So I remember I was on call with someone, one of my first check-off nights down there. Whoa, what do we do? And we're like Googling articles and just picked a random one.
Stop recording.
Yeah.
Yeah, so we all do kind of different things, and Amanda has like this very complex calculation involving hours on the insulin drip.
Yeah.
So I would say that's a good utility. I actually use that. The insulin drip's nice to have without any interference from outside insulin for a set period of time, whether it's 6 hours or 12 hours, that you can then extrapolate to their 24-hour insulin need. Then when you do start their long-acting, you have a pretty accurate indication of their basal rate.
Yeah, that's
So
what she
like
does.
by pushing stuff early on, even though theoretically it should be 24-hour, acting drug, but kind of muddies the waters a little bit.
I think it is interesting though. I feel like we actually get our patients out at Henry faster, our DKers, because we don't use endocrine though. And I've seen a small stuff. I'm not here that frequently. I've only seen a small subset of DKers here recently. But it seems like endocrine likes to allow people to be on the glucometer for a whole 24 additional hours. So they come see them and then they let them stay for a whole another hours after their anion gap is closed. And so I think at least in Henry, because we don't use them and we transition them as soon as their anion gap closes, we actually have a decreased loss of ICU stay because of that. Well, we could, at least in times that we put transporters in. So, which I think is I think it's interesting that us not using endocrine gets our patients out faster.
Or scary. I don't know, one or the other.
What's the readmission?
Yeah.
Are they bouncing back?
No, they don't bounce back from the floor.
I've had
But
one
is
or
that
two
because
bounce
nobody's
back.
looking?
They come out when they open back up to the floor.
Going to the floor or even coming back?
They don't come back from the floor, but they come back wide.
They come back from home, yeah.
So coming back from the floor and coming back from home with and without endocrine follow-up.
But so I would argue though that's because they're all non-compliant. So whether they had endocrine or not, it wouldn't matter. So you're gonna have that whether they stayed an extra day because we had endocrine or not. Because literally they all come in because of non-compliance, which would have not been affected by endocrine.
I would say in the more rural areas too, practicing down in the McDonough Henry area for a while, a lot of people use just their general practitioner. I mean, I was managing diabetes and people on 100 units of insulin to try to convince to go to endocrine and they wouldn't do it. I'm sure that happens, of course, up here. I think it's more so in the rural areas. And so even if you had them endocrine in the hospital, they wouldn't follow up. They don't want to go to a bunch of different doctors.
Mm-hmm.
But now, I guess I would say all that. That's the old way of doing things. We're trying to get into the new era. And so if your anecdotal observations are correct, we're doing better at Henry with ICU length of stay and worse with global glycemic control and avoidance of hospitalization outcomes. So then you would frame that and look at Atlanta and the anecdotal stories about there as well in length of stay in the ICU. But we're doing better on global diabetic control and patient population management. So who would win that? You probably would get a better grade at Atlanta in terms of global population management. Although length of stay is not something you want to concede and you're trying to make it shape that. And we're just now getting to the point where our hope is by the end of this fiscal year, we'll have a critical care dashboard. I don't know if y'all have seen the preliminary versions of it, but I'll make sure to send it out. That will maybe start to highlight that. And the diabetic control is not really reflected on this version. Probably the following year that we tighten it up. But then we can maybe start managing it. There's also been changes in the FEMA clinic structure now. That's now rolled up under the physician enterprise as of, I think that happened in the last 30 days. And so we're already getting the pressure to start managing outpatient like we've been managing also inpatient. So then we can start having those conversations.
Beth online made a good point. I would also think length of stay would depend on the cause of DKA. I would assume that a patient with severe infection would have a longer length of stay than ETOH.
All of my floor bounce backs from Henry have been Invokana induced DKA with the euglycemic profile who just come back for one reason or another.
You put them on Invokana. Is that they come in on that?
They come in on that,
Okay.
and then they get discharged from the ICU to the floor and then bounce right back. I've had 2 of them already.
Oh, yeah, I think I've seen that there. I haven't seen that in Atlanta yet. I wonder if there's a physician that likes it.
One of the newer diabetes.
Is it expensive? They're not getting it? Like it's not.
No, it's like a.
It's just the
like
drug
a
profile.
Adverse effect of the med. It's weird.
Anyone gotta get bold and try this next time they're on call?
Only if Dr. K says it's okay to do it.
Yeah. Now, I noticed in these articles, I like, so there's this new thing, we're trying to figure out how to make meetings more enjoyable, stimulating, how to make presentation more stimulating. This concept of cognitive dissonance, where you introduce something that makes the audience uncomfortable. When you say things like that, I feel a little uncomfortable, so that's probably a good thing. And the reason I get uncomfortable just surfacing that is just, if we show a study has no positive outcome from a p-value, why then would we argue to try it in the environment? Does that make sense? Now, if it lowers cost, I think that's a good idea. Now, Amy, if she was here, would say, if you're a believer in it, let's sit down and try to design a study that would show impact and how to use it. So I think that's where we get a lot of heat around the ECOS catheters until we got into the ultimate trial and started participating in the trial. Then everybody's like, well, we're studying it, okay. And so I think that's a good example of if this is Laura's future, managing DKA and trying to reduce length of stay around that, that's her career interest. And how can we work to get her sponsorship from the Virginie representatives?
I'm not going for all that.
Principal investigator.
Yeah.
I just think it's interesting it got picked up by the British Society when we searched a pretty good bit. There's only 2 articles of 40
Well, they
patients.
use it in kids. I think this has been studied a good bit more in children. And it's something that's being used more frequently. There's a bunch of trials about kids out there with this, just not adults.
So I think the trend on several of these tonight has been, does it cause harm? Doesn't look like it. And does it improve outcomes that we care about? Not so sure. And so if you wanted to do it, I guess in my own mind, for my own practice, like Bert was talking about, it's just going to add complexity to my management of these patients. I'm not sure I would want to go there. If I have one of y'all on call that just want to experiment with it, I don't think you're going to kill or harm the patient doing so. And so I'm probably fine with y'all doing that.
Cool.
I think it's going to get added at the end.
Especially the prisoners.
All the prisoners.
What about the pregnant ladies? They're always fun to experiment on, right?
Well, I think that can be somewhat a slippery slope and dangerous. I have to remind myself sometimes I'll try something like this. We'll go out and I'll do it. And my first case, it worked. Like, man, I got out here in 2 days. And now in my head, this works.
Confirmation bias.
Yeah, I have confirmation bias. Or it doesn't work and it doesn't work. And so even if we went out and tried it on a handful of patients and we all did 2 or 3 or 4 people, I don't think that would be anywhere near enough for us to really draw conclusions from it. So, our nursing staff, us as a team, everyone knows what protocol we're practicing now. So unless we're going to change it as a group and try to compile everyone's big experience, I think individual couple spots here and there really could have negative effect on any information that comes later down the road.
Well, they said in the study too, they're like, this is a pilot study. We just want to make sure, it's going to be safe for this little group, and is it even worth pursuing more?
I find frequently negative studies make that claim.
Any more comments about my study?
Thank y'all.
This is always higher than my doctor.